Hello students, this is Raghul, Assistant Professor in charge Department of Perfusion and Respiratory Care Technology, School of Allied Sciences, Vinayak Mission Research Foundation, Deemed to be University, Salem. We are going to see about the topic effect of organs during cardiopulmonary bypass. So usually cardiopulmonary bypass is a technique that has been incorporated in cardiac surgeries when the internal chambers of the heart is to be operated. So whenever the internal chambers of the heart to be operated, the heart has to be opened and all the chambers has been exposed to the atmosphere. So what is the work of the heart is the heart has to pump the blood effectively, right? So in terms of pumping the blood, the heart has to eject more forcibly. Force of contraction has to be in a greater manner, thereby increasing the force of contraction, thereby cardiac output has been increased. So now when using the cardiopulmonary bypass in cardiac surgery, what really happens is there is a solution that is termed as cardioplegia, whereas cardio means heart, whereas plegia means arrest. So cardioplegia is a solution that usually helps to arrest the heart during any cardiac surgeries. So while doing such cardioplegia solutions, the cardioplegia really helps to arrest the heart. Injury to some degree occurs in all the patients who undergo cardiopulmonary bypass. Usually the patients who are undergoing cardiopulmonary bypass, injury becomes a major product of at the end of the surgeries, right? So injury is directly proportional to the duration of cardiopulmonary bypass. Whenever the duration of the cardiopulmonary bypass has been increased, the extent of injury also increases. As a perfusionist, what I have to reduce the extent of injury means the usage of membrane oxygenators, arterial filters, bubble detectors. The usage of these safety devices have decreased incidence of serious injury. At first you have to understand what is the common basic physiology behind the injuries. Unless or until you understand what is the basic physiology behind the injuries, you can't able to decrease the factors that may worsen the effect of CPB. Unless or until you can't able to understand what is the basic thing that is happening behind the scenes, you can't able to understand only for this factor this injury has been happening. So understanding these factors may helpful to the perfusionist to overcome the extent of injury. What is the main goal of perfusionist is to maintain a normal physiological status during cardiopulmonary bypass. Now we are seeing about the topic of effect of organs during cardiopulmonary bypass. At first we are going to see about effect on lungs. So whenever the lung is undergoing cardiopulmonary bypass, most common serious injury of CPB that affects lungs is bypassing the lungs itself may cause injury, like atelectasis. Atelectasis is a thing that we will see in the later slides. So what is the second thing is that is known as SIR. The SIR is abbreviated as systemic inflammatory response syndrome. Usually what is the thing is complement activation, like C3A. C3 is a complement factor, whereas C3A is an activated complement factor, whereas C5 is a complement factor, whereas C5A is an activated complement factor. Activated complement factor 3 and activated complement factor 5 that may lead to the activation of leukocytes. Whenever the leukocytes is going to activate, which causes leukoembolization. Leukoembolization is nothing but the WBCs is keep on grooming together and then it is going wells elsewhere and then it helps to block the particular arteries. Depend upon the weightage of the embolism, it will help to block the particular arteries. When else the lung has been entered with the help of the cardiopulmonary bypass, that lung is termed as pump lung. So usually the lung should be congested with the intraalveolar edema. Usually the problem is usually not with the lungs, the problem is usually with the heart. But what we are doing, the term itself defines that is a cardiopulmonary bypass. So you are not only bypassing the heart, you are keep on bypassing the lungs too. Okay, so what happens here is the lung become congested with intraalveolar edema. Whenever the patient or supposed to enters into the cardiopulmonary bypass, when else the patient is supposed to bypass the lungs, it should be defined as pump lung. When else the pump lung has been defined, it should be termed as intraalveolar edema. The lung will be congested and it will suffers with intraalveolar edema, and it is a form of acute respiratory failure. Whenever the patient undergoes cardiopulmonary bypass and that lung is known as pump lung, with the help of the pump lung, the lung is definitely injured with the intraalveolar edema, edema, and it is a form of acute respiratory failure. What is the third point is capillary leakage in the lungs is a result of complement activation and neutrophil effect. So actually what we have seen in the last slide is systemic inflammatory response syndrome. Like we have seen that C3 activation and C5 activation that may lead to the activation of leukocytes, and that may cause leukoembolization, right? When else the leukoembolization has been developed, capillary leakage may be happen in the lungs itself. So what happens during capillary leakage? The colloidal osmotic pressure has been drastically reduced when the patient is on a pump lung. Okay, so what happens to the patient when colloidal osmotic pressure has been reduced? The pulmonary vascular permeability has been reduced drastically. Whenever the permeability has been reduced, what else may come in and what else may come out, and that may lead to the first point, and that is known as intra-alveolar edema. So overfilling of the pulmonary vasculature, just because of the colloidal osmotic pressure decreased, the lung becomes overfilling. Whenever the lungs become overfilling, there may be an increase in the hydrostatic pressure. Whenever the hydrostatic pressure has been increased, and that may helps to lead to fluid accumulation within the lungs. So as I had said already that whenever the patient may enters into the cardiopulmonary bypass, you are bypassing the lungs itself. Bypassing the lungs itself can lead to injury, right? So what is the injury is? That is known as atelectasis. Atelectasis is nothing but partial or incomplete inflation of the lung. Atelectasis is nothing but partial or incomplete inflation of the lung. Bypassing the lung itself may cause atelectasis. So can you please explain me within a simple term means incomplete deflation, static inflations, or intermittent inflations. These are the effects of atelectasis during cardiopulmonary bypass. What else patients? See, we have to undergo the preoperative lung functions. Unless or until we know what is the preoperative lung functions, we can't able to determine the lung has been worsened or the lung outcome has been increased or not. Okay, so what we have to undergo before undergoing cardiopulmonary bypass is we have to know whether the patient is taking smoking or chronic, the patient suffers with chronic bronchitis, the patient suffers with COPD or obesity or pulmonary edema, or we have to undergo what is the preoperative lung functions. So if the preoperative lung function has been worsening means the postoperative lung function also worsening. So what is the worsening thing is, it is known as atelectasis. As a perfusionist, I have to avoid the atelectasis that has been occurring during cardiopulmonary bypass. So why we have to avoid means the patient is coming and the patient is suffering with one diseases, and that is known as some heart diseases. What else it may be, some heart diseases the patient is suffering from. But what we are doing to the patient at the postoperative period, we are not supposed to introduce any new condition to the patient in the postoperative period, right? So as a perfusionist, I have to see, I am the one who handles the cardiopulmonary bypass, so I am responsible for the postoperative functions too. So as a perfusionist, what I have to do to avoid atelectasis is, I am using the arterial filter, I am using leukocyte depletion filter, and I am planning to maintain the colloidal osmotic pressure, and I am planning to go for the albumin coated circuit. So these are the safety devices that comes under the usual things of perfusionist. So by using an arterial filter, it removes the leukocyte clumps, platelet aggregations, and debris. So by using an arterial filter, it just filters out the leukocyte clumps, platelet aggregations, and debris. While using the leukocyte depletion filters, as we seen earlier, the systemic inflammatory response syndrome is just purely because of the activation of the leukocytes, right? So what we have to do, we have to deplete the leukocytes. So for that, we are using the leukocyte depletion filters, and by decreasing the colloidal osmotic pressure, there may be a chance of intraalveolar edema, right? So what we have to do, we have to maintain the colloidal osmotic pressure. If we are maintaining, as a perfusionist, I am planning to maintain the colloidal osmotic pressure means at the postoperative period there may be no chance of atelectasis to those patients, thereby the increasing the outcomes of the patient. There should be no morbidity, there should be no mortality if you are planning to go and maintain the colloidal osmotic pressure. So as I said earlier, injury is directly proportional to the duration of the cardiopulmonary bypass. If you are planning to reduce the duration of the cardiopulmonary bypass, definitely at the end of the surgery, the patient outcome has been drastically improved. So this is what the effect of cardiopulmonary bypass on lungs. Usually the lungs may suffer with atelectasis. The atelectasis is just because of bypassing the lungs itself may cause atelectasis, and also we can see as a perfusionist how we are going to handle such things, and how we are planning to avoid atelectasis is by using the arterial filter, leukocyte depletion filters, maintaining the colloidal osmotic pressure, the using of the albumin coated circuit, because whenever you are using albumin coated circuits, the colloidal osmotic pressure is to be maintained. So the last and the final point is, although least possible duration, whenever the duration of the CPB has been reduced, the extent of injury also has been reduced, thereby decreasing the morbidity rate. Now I think that you have understood what is the effect of cardiopulmonary bypass on lungs, and now we are going to see about the effects of kidney when the patient undergoing cardiopulmonary bypass. The blood flow to the kidney is affected by the composition of pump prime, sympathetic nervous system and hormones. See, when the blood flow has been increased to the patients, the GFR also increases. Whenever you are giving, as a perfectionist, you are giving some flows to the patients, right? So whenever the patient's flows has been reduced, the BP also to be reduced. Whenever the BP has been reduced, the blood flow to the kidneys also been reduced. Whenever the blood flow to the kidney has been reduced, the GFR also reduces. What is the normal GFR? The normal GFR is about 35 ml per minute per meter square per each kidneys. Like lungs, you have to always have eyes on the preoperative kidney functions. Unless or until you know what is the preoperative kidney functions, either the patient may suffer with any kidney disease or any acute kidney injuries or any renal stenosis or any renal carcinoma, you are not supposed to undergo cardiopulmonary bypass. Okay, so by using the intra-aortic balloon pump, so it also affects the kidney at the post-operative period. See what happens while using the intra-aortic balloon pump. What happens to the patient is, you have to place the balloon at the 3 to 5 centimeter above the renal arteries. So depend upon the height of the patient, usually the balloon size has been varied accordingly. Depend upon the height of the patient, the balloon size has been varied. So what happens here is, if you are choosing the balloon size inappropriate, means what happens to the patient? The balloon is going to occlude the renal arteries. Whenever the balloon is going to occlude the renal arteries, the blood flow to the renal to be reduced. Whenever you are planning to go for the appropriate balloon size, means the balloon has to be placed 1 to 2 centimeter below the left subclavian artery and 3 to 5 centimeter above the renal arteries. So if there is any inappropriate sizes, means the balloon will occlude the renal arteries, thereby reducing the renal blood flows. See, the next is extended bypass time. As I said earlier, injury is directly proportional to the duration of cardiopulmonary bypass. So here, if the duration of the cardiopulmonary bypass has been extended, means definitely the kidney will undergo any serious conditions. So the multiple exposure to angiography dyes is to the reasons for kidney damage during the postoperative period. Before undergoing any such things, you have to understand what is the preoperative function of the patient. What is the preoperative kidney functions of the patients? So if the patient suffers with diabetes mellitus, or if the patient is a female patient, or the patient is increasing age, or a congestive heart failure, peripheral vascular diseases, emergency surgery, or anemia, what else? These conditions are the pre-existing factors that will worsen the patient condition in the post-operative period, and particularly on the effects of kidneys. So what I am doing as a perfectionist to protect the kidney, what I am planning to go for, review the preoperative renal functions, the creatinine levels, urea level and GFR level. High level indicates, high levels of these things like creat high levels, urea high levels and GFR high levels indicates the post-operative renal failure. As a perfectionist, how I am planning to protect the kidney. And as a perfectionist, I have to review the preoperative functions, like creat levels, urea level and GFR level. High levels of these three things indicates the possibility of post-operative renal failure. We are planning to, as a perfectionist, I am planning to hemodilute the patients, and I am giving the maximum flows and I am always maintaining the mean arterial pressure greater than 50 mmHg. And also I am using albumin, but I am not supposed to go for the additional doses of albumin. So I am using the regular doses of albumin. From that I can able to maintain the normal renal regulations, and also to maintain the urine output either by kidney, if the preoperative function of the kidney has been is good, means we are using the kidney for urine output. If the preoperative condition of the patient is not good, means we are planning to go for the hemo concentration, or that is also known as hemofilter, or with the help of diuretics we can able to protect the kidneys to avoid damage in the postoperative period. I hope everyone understood what is the effect of cardiopulmonary bypass on kidneys, and now we are moving towards the what is the effect of cardiopulmonary bypass on neurological effects. The neurological effects during the neurological effects that has been takes place during cardiopulmonary bypass is usually minimal, but if it happens means a permanent damage may occur. Like if the patient suffers with any embolic events like air, blood clot, fat, calcific debris, circuit debris, atheroma, what else it may be, what else the embolic events it may be, if it is going to clot or if it is going to obstruct or if it is going to block the cerebral artery means it will definitely cause stroke. 5% of blockage can even cause death or paralysis. So if you are planning to avoid such neurological effect means what you have to do, you have to undergo what is the preoperative function, what is the neurological assessment of the patient. The neurological opinion is very much must in terms of if there is any neurological diseases or neurological conditions are there. So how do you manage? How do you manage such patients? If there is any neurological injury, this baseline information is valuable in assessing the extent of injury and treatment protocol. So what are they? The task of the perfusionist is to eliminate all sorts of embolism. As we seen earlier, the embolic events such as air, blood clot, debris, atheroma, like such things, right? So we have to eliminate such things, such embolic events. So for that what we are using? Arterial filter, gas line filters, we are maintaining the cooling and rewarming gradient in a proper manner. If there is any embolic events that has been entered into the patient means we are planning to go for RCP. The patient should be positioned in the Trendelenburg position with aortic cross clamp release. The patient supposed to go for aortic root venting, and you have to maintain the low pump flows or the low flow. If the patient flow is too low, it will cause hyperperfusion, and alpha start PH strategy to be maintained to avoid the neurological injuries. The effects of gastrointestinal tract during cardiopulmonary bypass. The effect of gastrointestinal tract complications are reported as occurring in only 2 to 4% of the patients following cardiac surgery. The patient undergoing cardiac surgery, only 2 to 4% of the patients suffers with gastrointestinal complications. So if any gastrointestinal complication may occur, what are they? Means the first thing is GI bleeding, the second thing is peritonitis, and the third thing is acute bowel obstruction. So this is what the GI bleeding means. So here we can able to see what is GI bleeding, and the second thing is peritonitis. Peritonitis is nothing but inflammation in the peritoneum, whereas acute bowel syndrome with abdominal distension, it is present here. You can able to see that. Okay. And now as a perfusionist, what I am planning to overcome, how I am planning to overcome the gastric intestinal bleeding, peritonitis, and acute bowel obstruction with abdominal distension. So CPB causes profound reductions in the blood flow in the splanchnic circulation. Whenever the patients undergo cardiopulmonary bypass, the splanchnic circulation has been drastically reduced. So how it is reduced, I will tell you in the later stage, okay? And thus leads to reduced perfusion to the gastrointestinal tract and its associated organs. So in terms of splanchnic circulations means the blood flow to the gastrointestinal tract, that is stomach and its associated organs like pancreas, liver, bile, and something else, okay? Whenever the patient undergoes cardiopulmonary bypass, the gastrointestinal tract blood flow has been reduced, right? So what happens to the patient? It may release a variety of vasoactive factors such as vasopressin, catecholamines, thromboxins. So what is these catecholamines are planning to do is it lead to the redistribution of regional blood flow. So if there is any reduction in the splanchnic circulation, it will release the catecholamines, it will release the thromboxin A2, it will release the vasopressin, thereby increasing the gastrointestinal blood flows. I hope you understand what are the complications of gastrointestinal tract, and now we are moving towards effect of blood. What is the hematological effects that has been taken during cardiopulmonary bypass? First, we have to know what we are doing to the blood. We are hemodiluting the blood, we are hemolyzing the blood, anticoagulating the blood, we are adding additional of drugs to the blood, changing in the coagulation ability, we are giving heparin rebound, postoperative bleeding, heparin induced thrombocytopenia, disseminated intravascular coagulation. All these insults that has been made to the patient is only by the cardiac surgical team. So we have to always have eyes on serum electrolyte levels, ABG values. If you are planning to, you have to lay down the criteria for blood products, either the patient needs some blood products or not. Okay, how we are going to manage these things? So I am using a hemoconcentration. That is also known as hemoconcentrator or a hemofilter. So hemoconcentration by adding the packed RBC, diuretics or MUF will be helpful to attain the hemoglobin. So if you are planning to go for a hemodilution and the hemodilution is very much excessive, so for that the patient HCT has been less than 30. What are you planning to go for? If the HCT is less than 30, automatically the hemoglobin level has been reduced. So what you will plan as a perfectionist, what you have to plan means you are planning to give some diuretics to the patient, thereby increasing the volume of urine output has been increased, thereby the HCT of the patient to be increased. So if it is not working means you are planning to go for a hemoconcentrator. What is the need of hemoconcentrator? As I said earlier, in the kidney itself, hemoconcentrator that is the thing which helps to remove the excessive amount of electrolytes or excessive amount of volume from the blood, thereby reducing the volume of excessive thing in the blood, thereby HCT has been increased. Whenever the HCT has been increased, the hemoglobin concentration also has to be increased. So what is the ultimate goal of the perfectionist is to maintain the normal physiological status during cardiopulmonary bypass. If you are planning to go for additional of drugs, use only when reasonable account to dosage. So see, there is adrenaline, you are not supposed to give adrenaline to the patient, to each and every single patient. If the patient needs for adrenaline, you can able to give. If there is no need of giving adrenaline to the patients, you are not supposed to give adrenaline to the patients. So what else the drug you have to give, you have to communicate with the team regarding the treatment plan. I hope you understand what is the hematological effects management too. Next, the effects of endocrine system when undergoing cardiopulmonary bypass. We are hemodiluting the blood, right? So the dilutional effects increasing the catecholamine release. As we said earlier, in the gastrointestinal tract itself, the release of variety of vasoactive factors, that means catecholamines too. The dilution effects increasing the catecholamines release, that may lead to vasoconstriction of the arteries. So increase the renin and angiotensin system. There is a hormone that is known as T3, triiodothyronine. So triiodothyronine is a hormone that always given to the patient when the patient can't able to wean off from cardiopulmonary bypass. If the patient can't able to wean off, we can able to give inotropic support to the patients unless or until the inotropic support can't be able to help the patients to wean off from cardiopulmonary bypass. Triiodothyronine has been given to the patients. It is given after going in bypass and then continue in the recovery phase if successful. Antidiuretic hormone vasopressin is also secreted from the adrenal gland, and this may lead to reduced urine output. Whenever the patients undergoing cardiopulmonary bypass, the temperature of the patient has been reduced. Whenever the temperature of the patient has been reduced, there is no aerobic metabolism takes place, the complete anaerobic metabolism takes place. Okay. So what happens to the patient? The patient's glucose level has been, the patient's glucose level has been completely increased because of the decreased metabolic rate, decreased oxygen demand. Whenever the metabolic rate has been reduced, the oxygen consumption or the energy consumption also has been reduced. There is no need of glucose to this patient. See, glucose level has been increased drastically when the patient undergoes hypothermia. So the insulin response is decreased during hypothermia. So see, the first point is insulin response is decreased during hypothermic bypass and the glucose level rises. As I said earlier, the metabolic rate of the patient has been drastically decrease. So just because of that, the hyperglycemia takes place. If the patient suffers with hyperglycemia, insulin response is to be reduced during hypothermic bypass. During the rewarming phase, the insulin response increases. What happens during rewarming? If the patient undergoes 32 degrees Celsius, you are planning to get back to 37 degrees Celsius. So you are planning to go for 32 to 33, 33 to 34 and then to 37, right? So during the rewarming phase, the metabolic rate of the patients has been drastically increased. So whenever the metabolic rate has been increased, the glucose has been absorbed. Whenever the glucose has been absorbed, only with the help of the insulin. So the insulin response has been increased during the rewarming phase. So as a perfectionist, you are not supposed to go and treat hyperglycemia during cardiopulmonary bypass. Why means, at the last point, the hyperglycemia usually continues for an hour or 2 hours after bypass is terminated. After the cardiopulmonary bypass is terminated, in the post-operative period up to 2 to 3 hours, after the 2 to 3 hours, the hyperglycemic levels becomes normal. If you are planning to go for treating the hyperglycemia, it will lead the patients to hypoglycemia in the post-operative period exactly after 2 to 3 hours. I hope you understand all the effects of organs, and now we are going to see about the triggers of organ damage. What are the triggering point that leads to organ damage? The key mechanism in causing organ damage associated with the CPB are the activation of systemic inflammatory response syndrome, which is an inevitable consequence of CPB. So as we said earlier, SIRS, which is the complement activation, C3A and C5 activation, which helps to activate the leukocytes, and that may leads to leukoembolization, right? So you are not supposed to activate the systemic inflammatory response syndrome. If the systemic inflammatory response syndrome has been activated, it will cause an inevitable consequences to the patients. So what we are doing to the blood, we are hemodiluting the blood, we are reducing the blood viscosity, and particularly these things are happening at the onset of CPB, at the initiation of bypass, right? This may result in alteration in the distribution of blood flow to the organs, and particularly the flow characteristics of blood through the capillaries has been drastically changed. In the effect of gastrointestinal tract, what we have seen, the splanchnic circulation has been reduced. As I said earlier, I will tell you later, right? See, the ischemic reperfusion injury to the heart, lungs and organs are supplied by the splanchnic circulations. So the blood from the splanchnic circulation has been taken up and it should be served to the areas where the ischemic reperfusion injury has been taken. Laminar flow rather than the pulsatile is always helpful to the patients, although the significance of this remains always controversial till now. What are the pharmacological strategies we are planning to give for antioxidants, proteolytic enzyme inhibitors, but none of these interventions are clinically meaningful impact. The usage of heparin bonded circuits, because the blood has been exposed to the artificial surface, right, foreign surfaces. So when the blood has been supposed to enter or supposed to touch the artificial surface or foreign surface, it may lead to contact activation and further it may lead to complement activation. These contact activations and complement activations can cause blood cell trauma. To avoid such things, what we are planning to do is we are planning to go for heparin coated circuits. The tubings and oxygenators and what else it may be, it should be coated with heparin, or else the heparin to be added in the priming itself. While we are adding some priming solutions to the circuit, we are giving heparin within the priming solutions itself. So whenever the blood is exposed to the heparin bonded circuits, there is no chance of, there is a decreased chance of getting the systemic inflammatory response syndrome. The hemofiltrations and ultrafiltration has been incorporated into the circuit. If the excessive hemodilation has been takes place, or excessive pro-inflammatory cytokines are there, or pro-inflammatory mediators are there, hemoconcentrator will definitely help us to overcome it. Current techniques have proven to be more effective in the pediatric than the adult. What we have seen in the first slide itself, complement activations, right? Complement activation may lead to activation of the leukocytes and that may cause leukoembolization. So what is the primary goal is, as a perfusionist, you have to always avoid the leukoembolization. To avoid leukoembolization, there are some safety devices that a perfusionist can able to handle. So what is the thing is leukocyte depletion filter. There is a leukocyte depletion filter, and that depletion filter will always filters the leukocyte. By filtering out the leukocyte, what happens to the patient? It helps to reduce the number of activated white blood cells. The leukocyte depletion have a protective effect in reducing the severity of the lung and myocardial injury in the post-operative cardiopulmonary bypass. Not only that, the most consistent benefit is found in high-risk patients. The use of leukocyte depletion filter is very much convenient in high-risk patients with the pre-existing lung disease. The patients already suffers with the lung disease, ventricular dysfunction, or those who are receiving the longer CPB time. Leukocyte depletion filter is a very much a supportive therapy to those patients. If you are planning to go for any blood transfusion, allogenic blood transfusions, the leukocyte will be present there. That leukocytes too may cause the systemic inflammatory response syndrome. So what you are planning to do as a perfusionist means you have to give leukocyte depleted blood filters. We have to use leukocyte depleted blood. So by using the leukocyte depleted blood, we can able to increase the outcomes of the patient in the postoperative period. We had seen what are the triggers of organ damage, what are the therapeutic strategies that has to be maintained as a perfusionist, what are the pharmacological interventions, what is use of hemofilters, hemoconcentrators, ultrafiltration, modified ultrafiltrations, leukocyte depletion filters. Right, these are the therapeutic strategies that has to be maintained by the perfusionist throughout the cardiac surgery to improve the effect of organs during the postoperative period. And last but not the least, we are going to see what is the effect of heart during cardiopulmonary bypass. So what is the thing is, this is a major factor, right? In terms of cardiopulmonary bypass, cardio becomes the first thing, right? So in terms of heart, how the heart is exposed to cardiopulmonary bypass. The period of cardiopulmonary bypass during cardiac surgery is divided into 3 phases. Usually it is divided into 3 phases. The first phase is onset of CPB, the second phase is aortic cross clamping, the third phase is reperfusion. What is the first phase? The first phase is onset of CPB, the second phase is period of cross clamp, and the third phase is rewarming period or reperfusion period. During the period, the heart is subjected to injury from microembolia. See, still now the heart has not exposed to the external atmosphere. It is inside the shell, right? It is covered by the sternum, it is covered by the pericardium and somewhat else. It is covered by the thymus, what else it may be. But now, during the cardiac surgery, the sternum has to be opened and the heart has to be exposed to the outer atmosphere. So there may be a chances of microembolia within the luminal surface of the heart, or the microembolia may entrined into the muscular trabeculae, what else it may be. These injurious effects incurred from these insult, together with the potential of inadequate myocardial protection and distension of the flaccid heart during the period of cross clamping. Whenever the heart undergoes cross clamp period, it should be an insult to the heart. We are not allowing the heart to be worked normally. We are planning to arrest the heart. Heart can able to contract. Heart can able to give some amount of cardiac output. But what we are doing, we are just insulting the heart. You are not supposed to do this, man. We are not supposed to go and get it. You can't able to give enough amount of cardiac output. So this is an insult to the heart. You are saying that the heart can't able to do anything. See, so from this insult, it may be result in inadequate myocardial protection, and it also lead to the distension of the flaccid heart. All these insults may result in myocardial edema and reduced ventricular contractility, and these two things may occur and then continue into the post-operative period. So myocardial edema is a serious complication in the post-operative period when the heart is supposed to go for the cardiopulmonary bypass. Furthermore, the heart is subjected to excessive preloading or excessive afterloading during the weaning from cardiopulmonary bypass. What happens during this period? Left ventricular end diastolic volume, myocardial wall stress, and the oxygen consumption are all has been increased. When all has been increased, there is a deterioration in the cardiac function. So the postoperative cardiac function has been drastically reduced. What is the conclusion? What I am saying at the end of the day is, the ultimate measure of the success of a medical intervention is its ability to improve the patient's outcome at the postoperative. It has to be increase the quality of life for the patients. There is much evidence to show that when the patient undergoing any cardiac surgeries or any cardiopulmonary bypass, both mental and physical health are improved after any cardiac surgeries. The cardiac surgery with CPB or without CPB that yield same and similar results. This is a testament to the fact that CPB provides a safe and effective means for performing cardiac operations. So at the end of the day, any organs that are supposed to undergo cardiopulmonary bypass, with the additional interventions, with the advanced interventions, as a perfusionist we can able to get over it. By understanding the basic physiology of injury, we can able to easily overcome it. At the end of the day, what is the take home message is, it's not about having the right opportunities, it's all about handling the opportunities right. Thank you students, thank you so much for watching.